Okay, thank you.
Thanks, Camper.
All right, so my name is Dr. Arvind Janab. I'm really pleased to welcome Dr. Jeffery Dusek here to present to us today. So thank you for joining us, everyone. Just background, I'm the medical director of naturopathic medicine at UCI. If you were there earlier, you know it's been almost 10 years in this role, and seen a lot of speakers come and go, and I've learned every time a new speaker comes. So I'm looking forward to hearing Dr. Dusek's presentation today. I'll be the moderator, so I won't speak too much. The real star here is Dr. Dusek. Before we start, just a few housekeeping items. So this session is being recorded. We'll send all registrants the link to the recording, and we'll post the link on the event webpage for future reference. Everyone will remain muted in this presentation to limit distractions, but there'll be an opportunity to communicate with us and ask questions in the Q&A feature at the bottom of your screen and at the end of the presentation. The Samueli-Institute is committed to whole person health research, education, and clinical care. Our interdisciplinary researchers are dedicated to exploring the science of disease prevention and treatment. This series is brought to you to share the promising integrative health research that's occurring throughout the Institute's pilot studies, grants, and Samueli Scholar Awards. To date, the Institute has supported 25 investigations with the potential to enhance our understanding of integrative practices. And for more information, you can find details on our website at sci-hi.uci.edu. Our speaker today is Dr. Jeffery Dusek. Dr. Dusek is a professor in residence, Department of Medicine, University of California in Irvine, and the director of the Outcomes Research, Susan Samueli Integrative Health Institute, Irvine, California. Dr. Dusek has 25 plus years of experience leading innovative integrative health and medicine research at prominent institutions in the United States, with funding from National Center for Complementary and Integrative Health of the National Institutes of Health and the Centers for Disease Control and Prevention. Dr. Dusek and Dr. Shaista Malik co-lead the BraveNet practice-based research network, which includes 26 well-known integrative medicine programs and clinics in the United States, Canada, and Australia. Dusek was one of two principal investigators of BraveNet's 5,000-person outpatient study entitled Patients Receiving Integrative Medicine Interventions Effectiveness Registry, which is also known as the PRIMER study. Currently, Dr. Dusek is one of two PIs of a multi-year NCCIH R01 grant to examine the use of acupuncture as a pain-relieving intervention in several emergency departments across the US. In addition, he and his colleagues were recently awarded R1 grant from NCCIH focused on the use of music therapy for pain relief in persons with sickle cell disease. He and his colleagues recently received a U24 award from the NCCIH to launch a new collaborative network of individuals with expertise in music therapy, basic science, mechanistic research, and integrative health research. Both R1s and the U24 utilize the BraveNet PBRN to provide a nationwide and multi-institutional collaborative environment. His research has been published in eminent journals, Journal of the National Cancer Institute, Circulation, JAMA Network Open, and the Proceedings of the National Academy of Science. His research has been featured in such venues as the New York Times, Washington Post, Boston Globe, USA Today, and National Public Radio. That's really impressive, Dr. Dusek. I know I'm going to pass the baton to you soon, but I just wanted, to say I'm learning a lot about what you do as we engage in this live. So I'm really looking forward to hearing your presentation and learning more over the days. So please join me, everyone, in welcoming Dr. Dusek, and I'll step out and give you the platform.
Great. Thanks, Dr. Janab. So today I'll talk about acupuncture in the emergency department for pain management. And this is a BraveNet multi-center feasibility study, and it's called ACUITY. And you'll see in the bottom some of the collaborating institutions, which I'll talk about in more detail. But before we get there, let's get to next slide. It's not moving on my screen. Okay. There we go. What we should know about pain in the US is pain affects an estimated 100 million adults in the US. The annual costs related to pain is roughly 560 million to 635 billion. And of course, that's 10 years old. So the true cost of this care has increased dramatically. Pain is a public health problem. It's a major driver of health, seeking medications, disability, and a key factor in quality of life and productivity. In the emergency department, acute pain is a lot of visits. There are 151 million emergency department visits in 2019, but 78% were for acute pain. Acute pain continues to be a problem to manage in the ED. Opioids remain a part of the guidelines for acute pain in the ED. And there was a recent study where 17% of opioid naive patients who were prescribed opioids for pain in the ED were still receiving opioids 1 year later. Now, 17% seems like a probably small number, but that's like if you or I were going to go to the ED with no prior exposure, have some pain, get opioids, 1 year later, we'd still be taking those. So I think we can see the ramifications of that not being positive for the health of Americans. So a couple of years ago, there was a nice systematic review that was non-pharmacologic pain medicine in emergency department for acute pain. This is out of Duke University. And the whole idea was to understand in prior papers what we saw with non-pharmacologic intervention. So 56 studies met the inclusion criteria. 10 of those were studying acupuncture, 6 studied physical therapy. Most were studying for musculoskeletal pain. 42 of the 56 studies reported at least one improved outcome after the intervention. Furthermore, 23 of the 56 studies reported pain control or relief compared to control group. 24 had no difference, and 9 groups had no control group, so there was no comparison to be able to determine that. Meta-analyses of 22 randomized controlled trials showed a difference of 0.46 units in favor of non-pharmacologic interventions. That is, again, statistically significant. But the conclusion overall was non-pharmacologic interventions are often effective in reducing pain, but most existing studies are small, warranting further investigation into the use of optimizing ED pain management. So the idea is that ED is an opportune place. There's a lot of acute pain. Opioids are so widely used, and non-pharmacologic interventions are promising, but more work needs to be done. So I'll get to you to talk today about acupuncture in ED and looking at BraveNet, which is our multi-site group, which I'll talk about right now. So the purpose of BraveNet, or the mission, is to conduct and disseminate high-quality, practice-based research that evaluates the effectiveness, safety, and cost and impact on patient experience of integrative medicine approaches. These include acupuncture, massage, in some cases, naturopathic medicine, chiropractic care, integrative medicine visits, further. We're now actually, Dr. Janab, we're now 29. We just grew again. We're now 29 sites, and we focus on patient-reported outcomes in real-world clinical settings. A lot of our work's been working on observational ambulatory integrative health and medicine, but today I'll talk to you about a randomized controlled trial. So at this point, BraveNet's starting to do both randomized trials across the network as well as across-network observational research. So this is a nice view of BraveNet. You can see quite a bit of folks in the California area, like quite a lot in the Northeast, and we have a missing swath up in the Midwest. So again, some work for us to do, but we've now added an Australian site, a Canadian site, as well as a Brazilian site. So again, this idea of working together and finding cross collaborations across either international or national regions is very important to us. Oops, get back to that. And you can see here some blue ribbon places. We've got Duke Health, we've got University of Washington Family Medicine, we've got Northwestern. We have 4 UCs, UCI, UCLA, UCSD, and UCSF, including Scripps. We have 5 in California. So you can see we have a nice breadth, and we've been on a growth spurt. So a lot of our work has been done with 17 centers, and now we're now looking to expand the network and also look for opportunities to support research across the network. We have a number of sites that are focused on children's health, so Children's Hospital of Philadelphia, The group in Columbia is focused on children's health, as well as Connor Whole Health. So there's some pediatric groups. There's some groups that are focused on cancer. In this case, we'll be talking about sites that have relationships with EDs across their institution. Before I get to that, I'm going to talk a little bit about acupuncture in the outpatient environment. If you ever had acupuncture, this is very similar to what you might see in an ambulatory or outpatient clinic. It's spacious, it's relaxed, it's quiet instrumental music, softly lit, pleasant smelling. It might be some lavender or a candle. You can see a candle there on that shelf that is burning. So it's really nice sense. So you can see some of the non-specific effects of acupuncture could be driven by some of these areas or these factors that are eliciting a relaxation response or calmness. Now, contrast that with the ED, where you have it's cramped, stressful environment, loud beeping, brightly lit, and offensive smelling. So if you've ever been to an ED, which I have been recently, it can be a long wait. It's a lot of stress. And again, there's just a lot of, it's not that relieving of tension that you get when you walk into an ED where there's fluorescent lighting and other types of things versus that ambulatory outpatient setting where most integrative medicine acupuncture is given. A couple of years ago, we presented a protocol. So again, all of our work, we really try to ensure is out in the public domain in peer reviewed. So this is NIH funded, the National Center for Complementary Integrative Health funded this multi-site feasibility study. And again, we have a number of sites, which I'll show you in a second. So we've got a coordinating center, Albert Einstein College of Medicine. We have a clinical coordinating center, what was my home institution until recently. I joined UCI just this year, was Case Western University Hospitals, as well as Vanderbilt and UCSD. So the idea was Cleveland, Nashville, and San Diego were ways to a different population, different geographic parts of the US, with the idea of bringing acupuncture to the emergency department. I had done some preliminary work when I was living in Minnesota and working in Minnesota at an institution, Atlanta Health, and we had done a pilot study that was very successful. So we were able to petition to the NCCIH to fund this R01 feasibility multi-site study. So what does that mean for a multi-site study that's feasibility? So one of our goals was to develop a responsive acupuncture intervention. I'll talk about that in a bit later. The second game was to implement a feasibility randomized controlled trial in 3 emergency departments across the Brave Net. And then 3 is to assess the implementation using qualitative interviews and structured observation. I'll talk a little bit about each of those just to give you a sense of what we have found. Okay, so the treatment, acupuncture for pain management in the emergency department versus usual care. The acupuncture was delivered solely in the ED. There was no out of ED interventions. The outcomes were assessed before and after treatment, which is about 45 minutes to 60 minutes later, as well as 1 week post-ED visit. The measure of success was, can we recruit? Can we retain individuals? And can they adhere, the acupuncturists adhere to the protocol that we developed? And then we have inclusion criteria include adults, ability to communicate in English, level 3, 4, and 5 on the emergency medicine triage scale. So think of 1 as a gunshot wound or a motor vehicle crash. So 3, 4, and 5 are where it's not acute injuries, but there certainly can be, and has been for this case, acute pain, but it wasn't as if there was life-threatening issues. These are issues where it's acute musculoskeletal, back pain, pelvic pain, non-cardiac chest, abdominal pain, headache pain, and what inclusion criteria required a greater than or equal to 4 on a 0 to 10 numeric rating scale. So where 0 is no pain and 10 is maximal pain, that'd be 4 or above. And 4 or above is classified as moderate to severe pain. So the mild pain, 0s, 1, 2, and 3, are not eligible because we really want to ensure this is delivered to folks who were where opioids would be a possibility of being delivered in usual care. Exclusion criteria: fever exceeding 100. We're actually going to make that 100.7 for a future study. Chief complaint of psychological or psychiatric concerns. So sometimes people come to the ED have some challenges, and certainly we need to have people be able to participate in the study, both in that ED session, but also contact us a week later. Chief complaint of migraine. Typically in most EDs, the migraine population gets some kind of cocktail that includes a pain reliever right away. So that could influence pain relief. So that was very important to avoid that. Current pregnancy, just because pregnancy has some ramifications for other health, and we still had to make sure this was safe for everyone. One of the bigger things what we did was we had self-reported or documented opioid medication taken orally within 4 hours as an exclusion criteria. And the point of that was we wanted to make sure that we weren't taking credit for someone taking a Percocet before they got into the waiting room or the treatment center or the triage center, or if opioids were delivered as we were in the screening process. So we didn't want an opioid, which can take about an hour to kick in, to influence the pain outcomes. So we wanted to make sure that that was something that was not happening before people enrolled in the study. Also, based on prior studies, presenting with a chief complaint of joint dislocation or bone fracture were thought to be exclusionary criteria. And then as the study was conducted during COVID-19, confirmed or suspected COVID-19 was a, exclusion criteria. So let's go get a little schematic here. So you see on the left of the screen, they admit to the ED. They're triaged by the ED staff or study staff, and our study staff does pre-screening. We also looked on the EPIC boards with a track called a track board. We could see individuals who were their age, their pain scores, the ailment that they have to make sure that they were met our criteria. The patient's roomed. Now, in this room should be in quotation marks because during COVID, a lot of care was happening in hallways, in waiting areas, because the volume of the ED was tremendously high. So roomed was ideally what we wrote for the grant, but what happened was patients were seen by a provider. And that's what, and then the provider signs the consent form saying this person could go without pain medications for 1 hour. There's no imaging happening or needing to happen immediately that would require them to be excluded from the study. So we want to make sure there was not a condition where they had to be treated immediately for pain. Obviously, they didn't come to the ED for the acupuncture study. They came to be treated. So we were looking for those individuals where there could be a gap in their pain medication treatment to participate in the study. Our team then completes the screening. There's a consent form and baseline completion. They're randomized, and we get pre-scores, and the pre-scores are, again, on a tablet. So we are, at that point, unaware of the patient's pain, or in this case, also pain and anxiety scores. We want to get their baseline scores or their pre-scores. And we've already made them eligible for the study. So generally, we're expecting those scores are still going to be greater than or equal to 4. But those are collected where we don't know those scores. At that point, acupuncture delivered, and the post scores are collected about 45 minutes later. Or if you're in usual care, the usual care happens as determined by the provider, and then the usual care post scores are collected. And then both groups go back into usual care and then are discharged. So one of our big goals was recruitment. So again, UH was the University Hospital in Cleveland. VHUMC is Nashville, Vanderbilt University, and UCSD is San Diego. So again, looking for screening, we screened 1,134 individuals. And it was about 6 months of recruitment across sites. So this is, again, for our pilot study, we're trying to make sure the protocol that worked in Minnesota was translatable to 3 different EDs that were de novo to acupuncture. We approached 220 at UH. We 300 at Vanderbilt, 112 at UCSD, a total of 632. And again, the approach is less than screen because, as I mentioned before, not all folks who are screened will actually meet eligibility criteria. So they may have a pain of 2, according to their triage, or they may have just had an opioid. So again, of those individuals that we approached, 632. So we enrolled 61 of 220, 49 of 300, 55 of 112, overall of 165 of 632, which gave us about a 26% recruitment rate across all 3 sites. But you can see quite variability between Vanderbilt and UCSD. We don't really know why, but we're certainly exploring that. But it does speak to why multi-site research is important, because were I running this study just at UCSD, I would think, oh, it's quite easy to recruit participants. where I run this study just at Vanderbilt, say, oh, it's quite challenging to recruit participants. So this sense of doing multi-site research gives us generalizability and also a better swath of the participants across the US. So 26% was our what we received. We then enrolled 165 again across the sites, so a little higher recruitment at UH versus VUMC just based on whatever happened. We did actually, Vanderbilt was having challenges, so UH had opened up enrollment one more time for another 2 months to meet our eligibility criteria goal. We were shooting for 55 across each of the sites on average, so that's what gave us that amount. Pre-scores, we looked at about 95% of those. We had a little challenge with the site at UCSD. As I mentioned before, we had a tablet, an iPad, and there was a glitch in this program called REDCap that was communicating with the tablet for the first number of individuals. But of course, we do data collection review pretty routinely. So we caught that after only 8 participants. So those 14% that are missing at UCSD was just a glitch in the programming or the Wi-Fi connection to this REDCap program. So again, which is why we're doing this multi-site feasibility, because now we're aware of, by virtue of using this iPad program, we want patients to be honest in their reporting of the pain to us. We don't want them to be feeling that they have to please us. So we don't want to know the pre or post score. We want to make sure that's completely honest to them. And certainly if they're having no change in pain, we want them to report that. If it goes up, we want them to report that, or going down. So we don't want to have them have any influence on that. And that tablet allowed us to do that. But of course, you can see what happens when you have technology sometimes. And then at the post sessions, we had 91.4. So sometimes things happen in the ED where patients then, where there was not thought to have imaging needed, image, or they leave against medical care, so what they call AMA. So some people do take off or are unavailable afterwards, but we did capture the large majority, and over 90% was our goal. So we felt like we met that. So one of the really cool things about the acupuncture in the ED is we're really looking to enroll a group of individuals who aren't typical integrative health and medicine recipients. So if you think of most integrative medicine studies, we see women of middle age of means. So in this case, we have 57% of the individuals in study are women, which is what it is. Middle-aged, of course, that certainly is what we saw here, 44.4 years, 17.1. We saw a huge proportion of Black African-American individuals, 44% of the population, and white was 43. So again, this is something that one of our goals is to ensure that integrative therapies are more generalizable, both within region of the country, but also in socioeconomic status. Hispanic Latina was 13.2%. Same thing with education. So we're looking at no high school diploma or high school equivalent was 36%. Less than $50,000 of monthly income, or yearly income, sorry, was 62%. And then Medicaid was 26%. So you can see we're enrolling a group of individuals who don't have education, don't have a lot of family wealth, and are on Medicaid. Again, with this idea of, can we bring the integrative therapies to an environment that can really have impact that will reflect the geographic and ethnic diversity of the US. Location of pain, so we took all comers. So we took abdomen, head, flank, chest. It was any kind of pain that was 4 and above. Except those ones I excluded, with the idea of being generalizable. So some folks will say, well, why don't you just run a low back study? The trouble is, low back isn't the only thing that people come to the ED for acute pain. So when I spoke to my clinical colleagues, they kept saying, we really need something that's not going to be only for low back or only for headache, but that we can use in general if this works. If you show some efficacy, that we can actually have this be something that could be widely used across a lot of populations. So back was the highest enrolling, 34.4%. Extremity, that's arms, legs, 25%. Abdomen, 18.5%. Prior acupuncture, so again, across all 3 sites, 24% of individuals had some exposure to prior acupuncture. Again, that was important. It was non-exclusion criteria. but certainly something that was we wanted to note. And then, of course, seeing here, the average across both sites, or both groups, excuse me, was 7.3 with a 2.2 standard deviation. So 7.3 on a 10-point scale, 10 being maximal pain, 0 being no pain. So this is a group that has significant pain. So looking across the sites, we see the pre-score. So you can see 7.4 on the right there. There's some variability across the sites. You can see University Hospitals was 8.0, whereas Vanderbilt was 6.4. So again, this idea of doing multi-site research does allow for the variability of what you're seeing. And we didn't expect this, but it was certainly something that we were okay seeing. And looking to see post-score, we see overall 4.8 was the post-score when it was 7.4 pre. Usual care, the post-score was 6.4. So we see negative 2.6 units on a 10-point scale for acupuncture, negative 0.7 units for the usual care group. Now, one of the things with this multi-site feasibility study, NCCIH said, and I'm going to take this out of our, we thought we were going to do a just within group, like comparing pre to post within the acupuncture group or pre to post within the usual care group, not comparing negative 2.6 to negative 0.7. They said, nope, we want no statistics. We have not run that. We have no idea whether this is significant or not. We know we're underpowered. To run a study like this, we would need way more patients than 165, or in this case, 75 or so across both groups. So the goal of this was to recruit, retain, get some understanding of what that difference would be, and then to proceed with the future grants. So this is kind of a preliminary grant, but something that does speak to, it's beyond like a single site pilot study of like 50 people. This is now a pilot study at 3 different sites across the US with the same protocol, with all the same exclusion criteria. So again, this does speak to preparing ourselves for that next step. Going back to the acupuncture intervention, before we started the study, we convened what's called a Delphi panel of 8 experienced acute pain acupuncturist and myself. And Arya Nielsen is our colleague who is the acute pain expert. And the folks, Julie Olson, all the way from Bashir Young, are the acupuncture experts. And one of the things that we came up with is having this multivariate, or this multiple pain locations. We came up with this notion that we had to have lead points and points that were preferred for the acupuncturist to adhere to, and that would go from lead points, which are the dark green, secondary points are the light green, which are the bottom of the auricular points, and then any points in yellow were additional points that could be selected at the practitioner's discretion. So that whole right column were points that were thought to be not preferentially preferred, but because the acupuncturist sees the individual in real time, there was an idea to be able to personalize the intervention. And so what the provider would do, they would jot down either right, left, or center, LI5, liver 3, those top lead points, and they would delineate what they had gone to in that intervention session, or that acupuncture session. And we had every one of those acupuncture sessions reviewed blindly by Dr. Nielsen. And then we had a process by which to look at the fidelity. How much were they adhering to the protocol that we developed? And the idea is for acupuncture clinical trials to proceed, we think there has to be a protocol. It can't be, it's 6 different points and you have to use these, but some kind of what we call guardrails around having some points that are indicated, and certainly some points that are okay if they're needed by the person's condition, how they present. So we're hoping to expand these what's called the stricta and concert diagrams, our guidelines, which are the ways that clinical trials are described. So concert describes how the number of patients recruited, retained, how many were lost to follow-up, how many were that called flow diagram. And stricta goes through what was the acupuncture in the randomized trial. So we feel like there's one layer that was missing from both the stricta and concert diagrams, and that's what we're proposing to have to be at the gold standard. So one of the things that we described was like we have no number of needles. So you can see across 3 sites, the average was 13.2 needles. It varied a little bit across the sites. Needle retention time would average 23.5 minutes, again, varied across sites, and the session length averaged about 40 minutes. So again, you can see a little bit different across sites, not too bad, but just some variability. We have 5 stages to the fidelity. So there's this, they go through some steps that they kind of rub the part that's sore if they can. They do some assessments, so that's the staging. Needle sites, we expected there would be from this Delphi group, there'd be 1 to 18 needle sites. We allowed up to 20. And when we looked at, when Dr. Nielsen looked at the protocol, the fidelity monitoring, she was able to determine that 77 of 79 actually had up to 20 sites. There were one individual had 21, one individual had 22. So again, those were outside of the protocol. Needle retention time was expected range was 15 to 30 minutes. We allowed from 10 to 35, and we found 76 of the 79 times met our criteria. Session length was between 30 and 60 minutes, with a range of 20 to 70 being okay, and 77 of 79 met that criteria. Recommendations given, there's some things that acupuncturists do after giving acupuncture. They had to document those. That didn't happen in 2 cases. And then they had to complete the session forms, which all the groups completed. So we get a total fidelity of 98.1. So now we can start looking for future studies. What does that fidelity look like with regard to the aspects that would be achieved in an acupuncture intervention? So again, step staging, needle sites, needle retention time, session length, recommendations, completion of study forms. And then for this part, we did have some distal and local points, but my point here is to show you that of the 79 individuals receiving acupuncture, low back was 30 of them, 18 was abdomen, 11 leg, and 10 head. So just to give you that view. One of the things that we had done in this study was made the decision that we'd almost have a have needles will travel philosophy. And this was, we were awarded the grant in September of 2020. We all remember what was happening in 2020. And so we started recruiting in May of 2021. Things were still kind of crazy in the ED. So one of the decisions that I made was we don't want to have a room within the ED. Had we asked for that and required that, I think we'd still be recruiting for that study because rooms were hard to come by. Even the curtained areas were hard to come by. So you can see here is a private room happened 31 times. Semi-private room happened 7 times. And in the common room, waiting room or hallway happened 41 times. So again, you can see being nimble allowed for us to have that acupuncture delivered in ways, in safe areas within the ED that allow for this study to happen. And also not to be a burden on the study. If we were in a room for 30 minutes, that could really impact the slowdown of the delivery and the flow of the ED, which would really be a death knell for doing future studies. Positions. So positioning 25 position was a problem. So a lot of times people were only being in a chair, barely in a recliner. So sometimes if you have low back pain and you're in a chair, that limits the amount of activity you can have in the local areas of the back. So you have to go to what's called distal points that might be in your hands or other parts that are not near the point of pain. And you can, and what I didn't show you was in the ED, we probably should have a chair because sometimes in 25 times, the position of the patient was not suitable towards the how they want to treat. And these are how the acupuncturists said what were limitations of how things were, how their acupuncture, what were the limitations. 2 said the time was too short. 2, the participants in the middle of acupuncture got a phone call, again, by a family member. So again, that was challenging. Access to points, 31. So again, even besides the position, they couldn't get access to points, another interruption. So again, you can see this is very pragmatic. This is not that lovely room. You're there by yourself. It's a lovely lavender smell, no fluorescent lights. It's like all the things that could go wrong probably could have gone wrong. But, and as I noted before, there was still a 2.6 unit decrease in pain of those individuals receiving pain, even with all these limitations and challenges. So we asked providers, when the sites were all done recruiting, what their views were. One of the goals, as I mentioned, aim number 3 was understanding how this was going to fit into the environment. So 125 providers answer the question, how appropriate is acupuncture in the ED? You can see appropriate was 33, neutral was 34, very appropriate was 9. We also asked them how helpful it was. You can see here, somewhat helpful is 39, very helpful 17. So let me just do something and to change this to see very appropriate and appropriate, 42%. That looks better. So it's very appropriate. Neutral is 34%. So again, generally there were some curmudgeons, but only 24% thought it was inappropriate or very inappropriate. So again, that was interesting. No one knew that before. We really had no idea what providers thought. When looking at helpfulness, we have 56% with either very helpful or somewhat helpful. So again, we didn't know that either. Neutral is 30%. So again, we feel pretty confident that this is something that is going to be potentially acceptable. We also asked providers who had experience with acute. So we asked the 125 were people who had experience in the ED and just said, what do you think of acupuncture being appropriate? How about acupuncture being helpful? Now, if you said you were exposed to acuity, we said, how are you satisfied with it? Were you satisfied with how acuity worked or didn't work? And then how much of a burden was it? And again, doing my little trick here, 75% were either very satisfied or satisfied with acuity. They're actually, importantly, 0% were very dissatisfied. And then of the 32, burden, not a burden was 72%. An extreme burden was 0%. So again, this idea was it's mostly appropriate, it's mostly helpful, and certainly we were not getting in the way. They were satisfied how we were interacting in their ED for patients who are coming in, not for acupuncture, but for care. We also asked patient perspectives. We have some, so we had asked a question after their session. You can see that bottom bar, very satisfied. About 42% of the acupuncture group are very satisfied versus 18% of the usual care group. And then we looked at satisfaction with treatment. So the first question was satisfaction with pain management. Very similar, but the treatment themselves, we were actually a little surprised. A little bit higher, it's like 48% versus 23%. So again, a nice difference between acupuncture and usual care, such that acupuncture participants who did not go to the ED for acupuncture were satisfied with the pain management and the treatment. So in summary, the recruitment, despite challenges of launching and conducting during COVID-19, recruitment was achieved, 26%. 80% of subjects were African-American at the Cleveland site, 44% overall. 45% of subjects were Hispanic at Site 3, which is UCSD, 13% overall. Subjects with low income and public insurance were enrolled at a high rate. Retention, post-treatment, 91%. Adverse events, we measured adverse events at 1 week and 4 weeks afterwards, just to make sure there's nothing going wrong. We used the CDC questions that were used for the COVID-19 vaccine. So we got a lot of very non-serious, we had 2 serious effects. One person died, one person had a stroke. Of course, not linked to acupuncture or usual care. It was their medical condition that led to that. 60 adverse events were mostly mild and unexpected, or expected, excuse me. So it was like, my back still hurts, or yeah, my knee, which was hurting now hurts a little bit more. So they were really mostly just nothing that was related to acupuncture or usual care, just kind of aches and pains of going to the ED and having that pain to justify that. Acupuncture intervention, we had a responsive manualized protocol that was very positively reported by the acupuncture providers. 98.1% of sessions were aligned with the protocol, which is great. Uptake, providers generally found acupuncture to be appropriate and helpful. Acuity was not a burden, which we were concerned about. And then finally, acupuncture patients were more satisfied with pain management and treatment than usual care individuals. So where do we stand? So we have a strong framework for a future definitive study, which in the jargon they call UG3, UH3. We have just proposed what's called a superiority trial of acupuncture versus usual care in 5 EDs associated with BraveNet clinics, the same ones that we included, plus Irvine and plus a group in Worcester, Massachusetts, where the 2 PIs are, Diana McKee, myself, are at those institutions. It's a much larger sample size to test whether acupuncture improves pain intensity from pre to post compared to usual care. Acupuncture improves pain intensity from pre to 1 week. Acupuncture improves anxiety from pre to post and 1 week followed to usual care. And then acupuncture reduces narcotic pain medications utilized for pain control or the presence of narcotic prescriptions at discharge. And as you imagine, science is something that is not done individually. This is the crew. I was at Case Western until recently, but that crew there was amazing. Albert Einstein College of Medicine was amazing. San Diego, Vanderbilt, University of Massachusetts, where my colleague is. We had a monitoring committee that had to monitor every 6 months to make sure there are no adverse events that were egregious. And then we had acupuncture experts. So I thank you for your attention, and I welcome some questions.
Thank you, Dr. Dusek. Very interesting, and it just a quick personal side note, it reminded me of some hospitals I visited in Vietnam some years back where they include acupuncture and flash cupping for pain management in an ambulatory setting, and they were extremely effective and really efficient in delivering that care to patients. So that was a long time ago, and it seems so far away for us here in North America to start doing that, but this seems like a great first step. So appreciate what you shared with us.
Absolutely.
Yeah.
My pleasure.
I'm going to address any questions. I know there's a few questions, and I encourage others to please submit your questions for Dr. Dusek, and I'll read them. So I'll just take it from the top and go from there. So the first question is, are there well, the first one was actually already answered. It had to do with numbers at UCSD, and I think you addressed that. So we'll just move on. And the question stands whether UCI will be in the study in the future, but I think you also addressed that. So we're looking forward to seeing that. So the next question, since back pain was highest number, was it exacerbation of chronic pain or new onset of back pain? And is that information beneficial for the purpose of this study?
Yes, it was actually a mix between the two. And we allowed for either, again, as long as that pain score was between 4 and 10, again, with the idea that the person coming to the ED and the provider are caring whether it was acute or exacerbation, but in their goal to relieve that pain, they're either use opioids or some kind of non-pharmacologic approach. So we thought long and hard about whether it was important to restrict that. And given that the exacerbation had to be within a acute time frame, and we did have some small eligibility criteria within 72 hours had to be an exacerbation, it kind of all fits into that acute frame. So I would say it's a good question, but we took both.
Great, thank you. Next question is asking if you could refer to the mechanism of action.
It's a great question. I think if I could do that, I wouldn't be standing here right now, because at this point, there are a number of theories of mechanism of action. Certainly, inducing a relaxation response might be something that could be important in doing that. A lot of individuals like Helene Langevin, who's the NCCIH director, thinks that the fascia, that when you put the needle in and twist it, there's the fascia that has those like action potentials that has some facet to relieving pain. To be honest, it is not understood exactly how acupuncture relieves pain. Now, you might say, gee, we should know all this stuff. Well, there are a number of medications that we're still and have been curious for years about how they actually work, but were they to work, people were the FDA was happy to approve them. So again, I don't think because we don't know the mechanism of action yet, we should be so worried. But certainly there's a lot of effort going towards understanding that. Dr. Rick Harris, who's at SSIHI as well, he's one of the endowed professors. His goal is to understand the underlying mechanisms, especially for fibromyalgia, of how acupuncture works. So there's a lot of work that's ongoing. And I'm hopeful we have some explanatory mechanisms soon. But again, I won't hold my breath, but certainly there's a lot of effort going towards doing that. But at this point, we do not know how acupuncture is relieving pain.
Okay, thank you. And any future plans for pediatrics?
Yes, that's a good question. So part of, there's actually one group in New York, I think it's Columbia, has deployed acupuncture for pediatric pain. So certainly there's no reason why not. We focused we would focus exclusively on 18-year-olds and older because BraveNet to date has been focused on adults. However, we've just added the Columbia site. We have CHOP, And we know that University Hospitals in Cleveland has a really big pediatric program. So I think our next study will still focus on adults, but there's no reason why the pediatric folks should be excluded for future study. A lot of times review panels like to keep it consistent, knowing that things can change with pediatrics and adults, but I think I have no reason not to think that it would be really successful in kids.
Great, thank you. Ken, I've got one final question, at least from the list that was submitted, and it has to do with whether acupuncture treatments were performed after the emergency department physician saw the patient, or was it before? So
yeah, after. Always after, because that was one of the big things we had, was we wanted to ensure, that was really I was set in stone, like we really want to make sure that the patient had been assessed, because they're there for assessment, to ensure where they stood and what their acuity was. So it was always after emergency provider. It might have been an APP, advanced care provider, practice provider. It might have been an ED physician, but it was always an ED provider saw them and made that determination whether they could participate, which is why we had that consent form, which is saying there's no reason why they can't participate. So I think that was really important to work within the confines of the ED versus trying to kind of subvert what they're doing, which would have been a disaster.
Thank you. So there's a follow-up question about pediatrics, and it is, are there any additional considerations that would be needed for pediatric population?
Good question. I would say with regard to the acupuncture intervention, I might defer to my colleagues, but in what I've read, I would say no. I mean, I think there's certainly numerous ways to treat with acupuncture pediatric individuals. I mean, I think you might want to stop maybe by age 7 or so, or maybe 10, just to figure out what the low end would be. But certainly, I know physiologically there would be no reason why pediatric individuals would not be treated. Again, it's the age of consent, making sure that the participants understood what's happening. So again, you want to make sure that this is, as it's a research study, it's a little bit different than clinical practice. So we want to make sure that the assenting by the patient, consenting by the parents happens, because that's obviously what the IRB requires us to do. But so that's the only trick, would be just having that timing to have parent and a guardian be able to consent to the participant. But given the pain that kids see, given already the data that shows that acupuncture can work in certain pain conditions for kids, I would think it would be definitely a next step to go to towards that pediatric environment.
Okay, great. Thank you. I have one question of my own.
Sure.
And it has to do with the patient's responsiveness. So are you tracking patients that may be less or non-responsive to acupuncture and looking at what influences or factors may be contributing?
Yes, in fact, we explored thinking about that with our sample of 79 individuals, and the sample was just too small. But one of our sub studies will be and so our goal is to get an 800-person study funded. There'll be 400 individuals receiving acupuncture, 400 receiving usual care, and the idea would be then we could start looking to see that distribution, because we certainly saw some folks had dramatic changes in pain relief, and some didn't. And again, looking to see other characteristics that predict that. So like a predictive model where we'd say, put age, put economics, put all these different things, put condition, prior experience, and see are there any predictors that resulted in like a 2-unit difference. So a 2-unit difference is actually really important on that 10-point scale. That's generally where opioids land. So if you have a 2-unit difference, that's what you expect from opioids. So seeing 2.6 from acupuncture was quite good. But so again, it would be, we have a couple tables where we look at individuals who have more than a 2-unit decrease, and those individuals who their decrease is less than 4, because 4 is that cutoff of moderate. So there was a study that was in Australia a couple of years ago that was looked at that as a criteria for success. Greater than 2, less than 4.
Right.
And so when we looked at that, we had a higher proportion of individuals in the acupuncture group than usual care. But there, to your point, what is it about those people who respond and don't respond? And again, we couldn't explore that at this moment in time, just with the sample size that we have,
Right.
but it is on our radar, like a multi-site comparison or multivariate, sorry.
And I wonder how much attitude towards acupuncture or beliefs around its effectiveness play into that.
We have that. So again, what we didn't show is we're still going through this data. We did get expectancy of any pain medication and acupuncture in that group.
Oh, interesting.
So and then we also have qualitative interviews of individuals. So we got a little bit more data. I couldn't get into this presentation. We're still working on the papers, but expectancy is something we're currently exploring because that's something very important with the potential mind-body effect as NIH determines acupuncture is a mind and body effect. So again, we can't separate one with the other. So we have that expectancy information to still dive in through.
Okay, wonderful. Well, thank you so much for your time today and sharing this with us.
My pleasure, and thank you all for attending. And again, this will be on recording, but certainly reach out to Samueli for other questions. I mean, this is something that we're really trying to do now with the addition of myself and some other of the endowed scholars, is really trying to expand the work that's happening across the system as well. So we're looking to collaborate across UCI, collaborate across the UC system. So as I mentioned, we have 4 UCs now within the BraveNet. And we're starting to think about, can we do some work that's just within the UC group within BraveNet, because there's some really interesting things that are similar and different about how we deliver care.
Wonderful. Well, thank you. And I want to thank our participants for being here today. Just a quick housekeeping. Our team will email all the registrants the link to this talk, so you can listen to it as many times as you want over the next few days, weeks. We also hope you can join us for the next research webinar on October 23rd with Drs. Ama Ray and Dawn Bounds discussing UCI's Cypher Lab project stream. Students who are resilient, empowered, self-aware, and moving. Please look for an email to register, or you can visit our webpage for a link to the chat. Thank you again, and see you next time.
Well, thank you.
Thanks, everyone.